All right, business here. Hmm. All right.
Are you there, Rick?
What's going on here? Quiet lot today. Okay. So let's have a look. Who have we got? Big crew. All
Peace,
right.
brother.
I figured it was Jake who opened the meeting. I checked in 10 minutes ago, and since it was open, I gave me a little extra time. Eric, Jim Cameron, Eric, the Jim Cameron.
I've been filling in a few names, Rick.
Okay, that's great. Whatever you've got is good. Mel Smoke. Frida, Ron Shaheen.
Up.
Frida, Ron Shaheen, Sylvester. Okay. Alright. Oh, there's Ron Shaheen. Hello, Ron Shaheen.
Hi there, Rick.
Those of you who are on the phone, if you're wondering, it's because we have visuals. If people want to open their video, we can see each other. So right now I can see Eric, Ron Shaheen, and Peter Kafka. So that's why you hear me saying hello to them. Can't see me waving to them, but I'm known to do that. Waving to Peter. Okay, so I'll tell you who I can see who's on the call. There are at least two people on the telephone that we haven't identified yet. So Jake, Eric Bookbinder, Jim Cameron, Mel Smoke, Paul Frieda, Ron Shaheen, Sylvester Mann, Peter Kafka, and who else do we have on the call?
Jim Harrington, Rick.
Jim Harrington. Jim Harrington in Jersey, or what?
That's right. New Jersey.
Jim Harrington back in New Jersey.
That's right, from a very enjoyable dinner.
Well, how was the whole conference, though?
Oh, that was good. That was fine. Just 21,000 people.
Oh, only 21,000?
And me. You know.
Oh, okay. All right.
But a great dinner, Rick. Great choice.
Good. I'm glad you enjoyed it. I think Eric just slipped off out of camera. Oh, he's back. So we're just talking about the Chinese meal at Hunan Homes, Eric. I I told Eric to tell his wife that it was a terrible meal so that she wouldn't be too envious.
Yeah, it was very good. Thanks, Eric, for picking me up.
That was great.
It was great.
So Rick, I'm Rick. I always listen, on my phone. So
Yeah.
even if I'm not in the picture, I'm listening.
Okay. All right. Who else has joined us by telephone? We've got a couple of other people.
Rich Catapano's here.
Sorry, who was that?
Rich Catapano.
Oh, Rich Catapano. Oh, hi, Rich Catapano. How are you?
Fine, thank you.
Good, 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 good. And anyone else by telephone that wants to identify?
Paul Hobson.
Oh, Paul Hobson. Hello, Paul.
Yes, indeed.
Hobson. Where are you, Paul?
Week 7 in hospital.
Oh man. All right. Well, we'll get to you and we'll hear about it. I was hoping you were going to say to me at home. I'm sorry to hear that. And let's see, Jeff Ledoux's come in. All right. So let me go down my list. I think I've got everybody on here, and I'll do another roll call, and then if there's no one else that's joined us, we'll get cracking. So Jake Hannum, Eric Bookbinder, Jim Cameron, Mel Smoke, Paul Frieda, Ron Shaheen, Sylvester Mann, Peter Kafka, Jim Harrington, Rich Catapano, Paul Hobson, and Jeff Ledoux. Anybody that I've missed?
Mike Tamales.
Mike Tamales. Okay. How are you, Mr. Tamales?
Very, very good, Rick. Thank you for asking.
Okay. I'm glad to hear that life is okay there. Okay. So we don't have any new folks. A couple of people did write to me, so let me just check. Ron, I know, was one. Ron Shaheen was one. Just Ron. That was the only person that I got a note from. So we'll kick off with Ron. And then let me go down the list and see who else has something they'd like to raise today. Starting with Jake. Jake, how about you?
No, Rick, not at the moment.
No? Okay. Eric Bookbinder?
Yeah, I want to update on my status.
Okay. Venice Jim, how about yourself?
So far, I'm good tonight, Rick.
Okay. Mel Smoke, how about for you?
I'm good.
Okay. Paul Frieda, how about for you?
Can you hear me?
I can hear you.
Okay, good. It looks like I've had some audio problems. Anyway, I'm good tonight.
Okay. Ron Shaheen, we're going to come to you, so I know you've got something. You wrote me. Sylvester, how about for you?
I'm good tonight. Thank you.
Okay. Peter Kafka.
I'm pretty good. I'm doing fine.
Okay. Nothing special for tonight?
Unless we want to talk about this news release that about the study that confirms that ADT has a definite beneficial effect with radiation for people who've had prostatectomies.
Well, we can certainly come to that. It's something I've been going back and forth with somebody on, so I'll put it in. It looks like we're going to have time. So, Rich Catapano, how about for you?
I'm just going to listen in today.
Okay. Are you
Thank
sure you don't want to update us on this cystitis and everything else?
I'm still confused.
Well,
I
okay.
really don't have an update. I should be going to see my doctor soon and bring a lot of questions to him.
Okay, well, if you want time, we've got it. We can give you time today. So just let me know. Oh, look,
Okay.
Dr. Steve has joined us too. Great. Paul Hobson, I'm going to put you in to say something, if that's okay with you.
Okay.
Okay, good. All right. We saw a glimpse, we just got a glimpse of Steve, but now he's back. Hello. Okay. He's back. Jeff Ledoux, anything for you today? Jeff? Jeff Ledoux, anything for you? I guess he's not with us right now. I know that he's a little concerned about an inguinal hernia. So if we get Jeff back on the call, or when he comes in, we'll ask him if he wants to talk about it. Mike Tamales, how about yourself? Anything for you? Any updates? Anything?
No.
No?
I'll just be a fly on the wall today.
Okay. And Steve, how about for yourself? How about telling us about how your Provenge is going?
Yeah, I can talk about it briefly.
Okay. So let me just make sure that there's nobody else that's... Have I missed anybody? Did I not stop?
Rick, it's Jim Harrington. Rick, I don't have anything tonight.
Oh, sorry, Jim. I beg your pardon.
That's okay. That's okay.
And Bill Franklin, anything for you?
No, I'm good, Rick. Just wanted to listen in.
Okay. So I'm just running down my list. I'm just running down my list here, and it looks like I think I've touched base. Jeff, Jeff Ledoux? Are you back with us? Must have stepped away.
I wouldn't mind hearing from Paul over in Australia.
Yeah, no. We've definitely got Paul. I've got Paul down here. We have two pools anyway, so we'll have to find out. Maybe one of those pools is one of those pools a Jim Harrington? No, it's not one of those pools. It's not a Jim Harrington. I don't know.
Might be Mike Tamales.
Oh, one of those pools could be a Mike Tamales. Okay. Mike Tamales, just say something to us so we can see what number you are. Yes. Okay, Paul Hoibson. The one with an I is actually Mike Tamales. If somebody could change that, that'd be great. The one that says Hoibson is actually Mike Tamales. So I'll leave it to you or Jake to figure that out. Okay, let's
I think I'm back online.
I think you're back online too. We hear you. Would you like
All right,
to...
I will mute myself.
Okay, would you like to ask people about inguinal hernias?
If there's time enough to do that, I'm not sure that it's a fact, but there is some pain there, and I'm not quite sure what it's from.
Okay, so if we've got time, we'll touch base. We don't talk about inguinal hernias much on this call, but it might be today might be a good day to do it. So.
Okay.
All right, so let's start with Ron. Ron, you wanted to talk about chemotherapy and cystitis, if I recall.
Correct. If you recall, about 3 weeks ago, we talked about radiation cystitis of the bladder, and I was having some pain. Went in about a month ago, and my urologist diagnosed it as radiation cystitis. Scarring of my bladder from 8 years ago when I had salvage radiation to my prostate bed. Never heard about this before. Seems to be one of those things that nobody talks about at the time. But until you have the problem, then they talk to you about this possibility there. I could just tell you that I had 3 weeks of the worst pain of my life. I was on morphine. I lost about 30 pounds. It was really pretty agonizing, the pain that thing caused. It's just been the last, I would say, week, 2 weeks that I've been off the morphine, and the pain has stopped. The good news is the bleeding has stopped. So I'm pretty. I would say that it's probably this intermittent situation has settled down. So just thought I'd bring that up. It's I guess it's a result of our treatments as we go through. Sometimes we get it, sometimes we don't. I know you, Rick, you had a minor case of it.
Yeah, really minor. No, I didn't have any pain at all. But we've had other people recently who have had issues. Include from memory, Rich Catapano, wasn't that you that had issues with radiation cystitis recently?
Yep, that's me.
That's what I think.
I had the same, no pain though. I didn't have any pain. I just didn't know what it was, bleeding was about. But when I went in, they said they wanted to take a look inside. They thought what it was the cystitis, but I went in and they went in and they cauterized inside because it was all inflamed, they told me. They cauterized where it would bleed and stuff and around the neck. And I've been okay after going to a couple of bleeding sessions and stuff and more catheterizations. But now it seems to have stopped, and you know, now I'm left with a lot of leaking.
When did they cauterize you, Rich?
September 28th, December 28th.
Okay.
December, January, February. It's almost 2 months now. But in between, I've had, you know, a lot of bleeding and clots, and I had to go back in and catheter.
Yeah. The bleeding and the clots are lousy.
Yeah, I had to put catheters in twice because it would block my urine coming out.
Yeah.
I think through all of that, I don't know if they hit something or so I had all this bleeding, but now it seems to have calmed down.
And
so,
Ron, how about you? I mean, you had a lot of pain. I assume a lot of that must have been probably from the clotting, so that you had a lot of pressure on your.
I actually only had, you know, I early on it scared the hell out of me, but I think the first time I had to pee, and I went in there, the bathroom, and I couldn't go, and I just said, I'm going to just pee, and I put a lot of pressure on it, and I shot a blood clot across my bathroom that splattered on the wall. But it was the first time I realized, then I did some more reading, that that was one of the real problems of all the clotting, is it will clot up your urethra and you can't pee. So I think from that experience on, I made damn sure as much as I could that I peed, and I peed as much as I could, which was bloody and clotty.
Right.
But fortunately, I have had clear urine now for 3 weeks.
Oh, good.
And I actually had scheduled next week a pre-surgery for the catheterization I had set up prior. But I talked to my urologist today, and he says, well, hopefully this is gone into a remission, and we'll just keep our fingers crossed and move on.
So you're not. So right now you don't have to. You don't have to catheterize. Everything is working fine.
Nope.
Good.
No, but I'm back to normal, I suppose. I mean, that's one of my problems. The second problem I want to talk about is chemo. So.
Okay, so let's just tie up on the cystitis. I can only imagine the pain because I didn't have pain, but I have had kidney stones. So my guess is that it's probably very similar to the sort of pain you get when you got a stone going down the lower part and it gets stuck in the urethra, which is exceptionally painful. I mean, I know that.
Well, I had no idea, you know, that I would have pain, and I woke up in the middle of the night and I had my wife take me to emergency at Kaiser, and that's when they started giving me. I started the pain pill regime, and went through various stages of pain pills. But you know, the good news is the morphine helps. The morphine did the job.
Good.
And I suppose I take some lessons from this that as the cancer progresses and you get into other pains from this thing and you get onto these pain drugs, at least I've got the knowledge that the morphine will stop the pain.
Yeah. Yeah. I mean, the key there, of course, is to be ahead of the pain and not let the pain get ahead of you.
Exactly, and I learned that through about 3 weeks of trial and error with working with the nurses and stuff to try to get the delayed reaction or the delayed dosage, long-term dosage versus the pain breakthrough dosage. So,
right. Does anybody?
Did they ever mention for him to use a capsule called Elmeron? It's supposed to coat the bladder inside because the radiation had taken off all the protection.
you know, I had read about that, and I had it down on my notes to talk to my urologist about that. But when we first had two of our sessions, I asked, was there something that, you know, you can get into the bladder to protect this? And he wasn't very forthcoming. I mean, he didn't seem to indicate anything that he thought was workable.
Okay, and what was that other thing? The oxygen?
Oh, the hyperbaric.
Oh, the
Hyperbaric. Heard that'll even cure it.
Well, that's what I understand, and Kaiser doesn't do that. I think they have some association. We did talk. The urologist did say he had heard that there was some good results from that.
Okay. All right. I just thought I'd throw that out there. So
Yeah.
Thank you.
information I.
Yeah, hi, this is Jim Cameron in Florida. I'm having that problem, and I went to a urologist about a month ago, and he suggested the oxygen treatment. Next Tuesday, I'm going to another urologist for a second opinion, because the oxygen treatment, they tell me you have to go every day for 2 hours for 2 to 3 months.
2 to 3 months.
Yeah, every day you're in the oxygen cylinder for 2 hours, and it's 60 to 40 sessions.
Wow.
Yeah, so it's a big. That's my. And I talked to 3 different places down here in Florida. There's one not too far from my house here in Venice, and they said they've had good. All these places are wound centers, by the way, and they've said they've had very good success with radiation burns of the bladder in curing those.
It's not a bad, I mean, it sounds good, and I like to see what it looks like, because if you're in a tube, enclosed in a tube for 2 hours, I don't know about that.
Well, I haven't seen the tube. After I go to the urologist next week, I'm going to stop by the pain center to take a look at the facility. But they tell me that you can read in there. You can it's see-through. You can watch television.
Oh.
I haven't seen it yet. But I'm going to go over to the one here in Venice, Florida, after I go to the urologist next week. If this urologist tells me that the first urologist told me I should get it done, if this guy tells me I should get it done, I probably will do it. But I want to schedule so I can get it first thing in the morning and not use the whole day up just going for the treatment.
Yeah. And I would imagine if you don't have a bad case of it, you probably won't have to do it as long.
They said 40 to 60. Yeah, that's what they said, 40 to 60, and it depends on. Right now, I'm just starting to bleed occasionally, not much, just a little bit in my blood, and it doesn't even happen every day.
So,
yeah,
Do you have any idea how much they're charging for those sessions?
No, I don't. But it's covered under Medicare.
It is?
Yes.
Oh, that's good.
Which means,
And,
Ron, which means that, and Steve maybe knows more about this than I do with Kaiser, but if it is covered under Medicare and it's not offered, and there may be a way for you to petition to get it. Steve, how does that work?
Yeah, if it's an indicated service, Ron, you can definitely go ahead and get it as outside contract. Your doc just has to provide a external consult to whatever center does do it. I was just doing some reading on it, though. There's only been a couple papers on it, one in 1998, one in 2015, and it varies from 27% success to over 90% success. I haven't read the papers, but there's only been 2 papers written on it, so it doesn't look like it's something that's real mainstream, quite frankly. And it looks like it's an hour and a half to 2 hours, 5 days a week for 40 to 60 sessions. And it works by regenerating the blood vessels within the bladder. So I just did a real brief reading on it because I don't know much about it myself, but it's a pretty big commitment. You're talking about an hour and a half to 2 hours, 5 days a week for at least 8 weeks, if not more. That's a pretty big commitment.
Yeah, it's definitely an alternative medicine offering.
Yeah, well, like I say, there was a 1998 and a 2015 article. Those are the only 2 scientific articles written on it, which makes you think that it is a little bit out of the mainstream.
Now,
hey, when I checked down here in Florida, I think there was 42 centers in the state. It was a website I found that listed all the places.
Wow.
And quite a few of the big hospitals here offer it. I know Sarasota Memorial Hospital, which is a fairly big hospital down in Southwest Florida here, they offer it.
Yeah, when my wife had back surgery, they wanted to put her in the hyperbaric chamber. They said that the healing is twice as fast.
Yeah, I mean, hyperbaric therapy is used for a number of things, but here with radiation cystitis, what it's saying is the response rate is between 27 and 92%, and the recurrence rate is between 8 and 63% in these 2 articles. So when you see that variation like that, it probably means not a lot of patients, and it's not a very scientific study. It tends to make you think that it's kind of off the mainstream. When you get anywhere between 8 and 63% recurrence after you've had the treatment, that's a huge difference. I mean, that's pretty major.
Jim Cameron, I would also recommend you raise this this Elmaron with your doc too. The drug that Rich Catapano was talking about.
Okay, how do we spell that?
I think it's Elmiron. Is that right, Rich Catapano?
I'm wrong.
Let me just see. That's what I have.
Yes, you are correct.
Elmiron.
Right.
E-L-M?
I-R-O-N.
Oh. And it's very expensive.
And exactly, do you know how it works?
Yeah, you're supposed to take one pill 3 times a day, but the problem is it's like going into the barometric pressure. You got to take it 2 hours before you eat, and you can't eat for another hour or so after it. 3 times a day.
Indefinitely, or how long do you take this pill?
For your everlasting life.
Okay. And what's the price tag on it?
For me, it was like, with my insurance, it was like $400 a month. So it's very expensive. That's why I think the hyperbaric pressure is a much better deal.
Like I said, I talked to 3 different centers. I talked to the wound center here in Venice. I talked to Sarasota Hospital, and I talked to one other one. And they all quoted 90 to 95% success rate. They didn't mention the low number. They only mentioned the high number to me, and they didn't all about nobody brought up reoccurring. I didn't know, I wasn't smart enough to ask about reoccurring, but I will when I go next week.
Yeah,
I'm amazed that somebody could quote you a 95% success rate. Jeez.
well, you can quote anything you want based on your anecdotal evidence in medicine, right? I've had 10 patients and 9 of them responded, and of course I didn't see them after 3 months, so I don't know what happened after that, because it's not a study, it's an anecdote, right? So you got to be really cautious about these things that are off the mainstream like that. And Elmeron, I was just looking up that as well, is used for interstitial cystitis, which is not radiation cystitis. It's different. I used to see a lot of pregnant ladies that used to get that. I've never heard of it, quite frankly. I don't know what it does. It looks like some kind of blood thinner from what I'm reading. I don't know why it would work exactly, but it'll probably reduce the bleeding. I would have to think. I don't know. Read a little more about that one too.
Actually, Steve, that's now that you said that, that's what my urologist said. He says when I brought this coding thing up, he says actually that's something for interstitial cystitis, and says we haven't had any experience that did anything good for the radiation cystitis.
Yeah, interstitial cystitis is a different disease for sure,
right.
And I do know something about that, like you say, because pregnant ladies get it. And it's nasty as well. I mean, it can cause all kinds of bleeding and pain and so on, but it's different disease than radiation cystitis for sure. And so oftentimes you see docs saying, well, it's good for that, we'll try it for that, without any good scientific evidence. And I'm not being a naysayer about everything here, but you don't want to go out and spend, a lot of money on this stuff for the rest of your life and not have good evidence that's going to help you,
So, guys, I'm going to move on only because I see there's a few extra people that have joined us. I want to check in with them in just a minute. I want to get to Paul Hobson for as long as he's with us. And I also want to finish up with Ron. So, Ron, why don't you move on to the issues around chemo?
Well, thank you. This coming Thursday, I'm having to me, a critical meeting with my oncologist, but basically to decide whether we discontinue chemo or not. My last 3 sessions of chemo, prior to each one of them, my PSA has gone back up each time before the chemo after 8 months of it going down steadily. So our question is, right before I see him, I will do another PSA. I did not have any chemo in January, and now I haven't scheduled any chemo for February. So I've missed 1 session of chemo. So I'll do PSA next week, and we'll look to see how it's gone up. But I'm of the belief that we'll probably discontinue, which is a really hard thing for me. Emotionally, I feel like I'm sort of giving up. I mean, it's after 14 years of fighting this son of a bitch. I don't have any other options out there. I mean, I could do radiation 223. My doctor is very leery about that because I had a blood transfusion of 2 units last week because my hemoglobin dropped down to 8.1, and I've been having difficulty keeping my white blood cells up. And my oncologist there at Kaiser has had, he said 5 of his patients have never completed the radiation 223. They had to stop because it was screwing up their I don't know, bone marrow and all that stuff. So he's not a big proponent of that for me. So I guess this conversation is, okay, Doc, what's next? Do we just quit looking at PSA now? I just forget PSA, and we go on the rest of my life, whatever that is, with bone scans and CT scans? What's the prognosis now? We just live it out?
So, Ron, a couple of things I want to just clarify with you. Just the first is factual, which is that the most recent chemo you were on was cabazitaxel. Is that right?
That's correct. Yes.
And so you've done docetaxel and cabazitaxel. Any other chemos?
No other chemos and no other combinations. my oncologist is not. We talked about the platinum thing and that, and he's very anti that.
Okay, well we'll come back to that momentarily, because he may be anti it, but there's plenty of evidence and good evidential papers that suggest that it should be used. So if he's that anti it, the first thing I would tell you to do is have him call Andrea Hartstark up in Northern California, Permanente, because she's an author of one of those studies. He might not like it, but it works for some men if you can tolerate it. So, but before we get there, there's a few things there's one important thing I wanted to say. If you feel like you're having some emotional difficulties with where you are, I really recommend that you call into Jake's in the conversation call with John Teisberg and Jake, and I think Rico Boyd is going to moderate it this Thursday, right? Jake, this Thursday?
Yes, that's correct.
Right.
Thursday at 8 o'clock.
It's
8 o'clock Eastern time? 8 o'clock
Yes.
what?
Yes,
8 o'clock Eastern.
8 o'clock Eastern, same time as this one.
Nice.
And
Same number and everything.
Same number, and the purpose of that call is exactly to air out, drill down, however you like to put it, on these sorts of issues, which we don't have a whole lot of time to talk about on these calls. But that call, which is an hour and a half call, is dedicated to that. And
Great.
and I would really recommend that you participate in that call. And nobody is it's all peer-to-peer, just like this is, but there's an ear there for it. And some people are very optimistic, and there are some people on that call who are Eeyores. But it's a very good forum in which to voice those concerns, and I hope you consider calling in.
I definitely will.
Good. Now, as far as treatment is concerned, I was going to say to you, there are other chemos. We know that some of these other chemotherapy combinations, like etoposide and cisplatin and carboplatin, that some men respond to them. Some men have significant side effects from those drugs. Some men do not have significant side effects from those drugs. We've had both on these calls and people that I've helped navigate. But for a doctor to say, I don't like them, they just don't work, is a disservice to you, because they do work for some men. The fact is that...
Well, I would say, Rick, that his approach was that he was concerned about my tolerance and his experience he's had with me with the other two chemos.
Right.
And his recommendation was he was not sure whether my system would tolerate it and whether the risk-reward benefits were. He did.
That's fair enough. That's different to what you said before. If he's,
I didn't. Yeah.
If he's saying that maybe you don't tolerate it, but then the other way to go is to try it introduce that at a lower dose. I've seen men do that just to see whether it works. The other thing is that and we've talked about this many times, it's probably time that you need to get a comprehensive genomic sequencing of your bone, of a bone tumor.
Yeah.
And that is really, really, really important, because what happens with this disease, and we know it for a fact, it changes. It becomes a different type of disease over time, a different genus of disease. So it starts off as an adenocarcinoma, which is a hormone-sensitive cancer, and over time it becomes more of a small cell neuroendocrine cancer, which is a different type of cancer, which requires different drugs. And it's quite possible that its genomic profile changes over time as well. So much so that when they've done studies in places like UCSF, they've actually identified enough different samples to actually name a new type of prostate cancer. So what I guess I'm saying is, and I know it's difficult with Kaiser. It's a project that Steve and I are working on together to try and do something about. But for a man like yourself, it's really important that you get that gene, that tumor sequence, because there may be some drugs out there that you could respond to. And until you get the gene sequence, you don't know. Now, how do you get that gene sequence? Well, the way that we've seen, if the system itself doesn't have a proprietary laboratory, which a lot of the big hospitals do, is you have to use an outside lab. The outside lab that I like, is Foundation Medicine. If anybody's looked on our website recently, you'll see that we actually have the manager of patient advocacy for Foundation Medicine on our advisory board now. And I talked to them recently. I've been talking to them weekly. If you cannot get Kaiser to do it, and you might be able to, I'm going to turn this one over to Steve momentarily, but you can always go privately, and they will probably work with you to see how much of that they can shoulder, and I'd be happy to help you in the interim, because we know that it's an issue with Kaiser. But it's really time, and the best way to do it is to get a bone sample, is to get a solid tumor sample, which is not excessively, it's an interventionary procedure, but I know enough guys who have said that it didn't bother them very much at all. To say to you that it shouldn't be bad. On the other hand, Steve might disagree with me. I'll give him the chance to do that. But I know that the men that I've spoken to have not had a big issue. The other way to do it is with a blood sample, but you're not going to get anywhere near as good a result. So, Steve, you want to talk about this a little bit?
I'm sure. Well, not as good a result. I think with the liquid sample that Foundation Medicine does, you're not going to get as comprehensive a result.
Correct.
You're only going to be looking at 60 or so mutations versus as many as 500 with a biopsy, a solid tumor biopsy. So I agree with everything Rick is saying. I think if they're saying we're running out of options here, I mean, you may find by doing gene sequencing on solid tissue, if it's accessible, and of course they need to review your scans to see if there is an accessible lesion, you may find some drug that's not used in prostate cancer that might be effective for you. That's the whole essence of this, to steer your oncologist in terms of treatment. So I would definitely look into that if you're kind of running out of options. Let me just mention one other thing. You mentioned radium-223. So I think you remember I decided to go with 3 cycles of radium-223. My blood counts tend to be pretty good, but I did see a significant drop in my red count and my white count with it. And so that's why I opted to just do the 3 cycles. But it did seem to have a pretty profound effect. And if your lesions are primarily or exclusively bone, in other words, they haven't diagnosed liver or lung metastases, if it's bone metastases that you're dealing with, I wouldn't ignore the radium. I think the thing is about the radium, it takes about 90 days to get out of your system. The chemo takes about 6 to 8 weeks to get out of your system. So you're about, about 6 weeks out of the chemo now, something like that? Yeah. So I mean, if your hemoglobin's over 10 and your white count's over 3,000 or so, I mean, I wouldn't ignore the radium because it's very specific for bony lesions, and you can kind of, they say it's every month for 6 cycles and then that's it. But like I said, I chose to do just 3 cycles and then take a break because I'm still not into the 90-day nadir, in other words, with the depression of the bone marrow, and it's still, my blood counts have come up dramatically since I've been off the radium. But my PSAs have come down quite a bit, with that and the Provenge and so on. So I wouldn't ignore that. I think it's a good option in somebody who has bony metastases only.
I mean, the only thing I would say, Steve, is that with a hemoglobin of 8.1 going in, it's kind of low. I mean, I've just seen, if it were me, I would not do it because I've seen people do it at 8.1 and it's really finished them off.
No, they wouldn't even give it at 8.1.
Right.
No. I wouldn't even approach it at that. I mean, this would be down, you know, maybe a month or so and see what my blood sample looks like,
right.
You know,
right.
30 days from now, you know.
Yeah, presumably the hemoglobin is 8.1 because of all the chemo you've been on.
That's right.
Yeah, it is. I mean, it just, yeah. I mean, the accumulation, it's been 13 sessions, you know.
Yeah, no, so I mean, that's why, you know, and if your platelets and your white counts are doing pretty well, you know, hopefully if your hemoglobin comes up to above 10, then at least you become a candidate, and it gives you one option. It's pretty, I mean, you go in there and they give you an injection, takes like 5 minutes, and then you're done for a month, you know. It's no big deal. It doesn't have, you know, all the side effects of chemo. So I wouldn't exclude it. I mean, I think it is, for bone-specific disease, it's still pretty good treatment.
And while Dr. Lee has said that he's not encouraging me to look, you know, to do it, he says that it certainly is another option out there, and it has shown some life extension to it.
Yeah, they all have. I mean, same with the Provenge. And the other thing is, you know, and Rick and I have talked about this as well, you know, Prostvac is going to be approved hopefully in the next few months.
Right.
And Prostvac with the checkpoint inhibitor may be very powerful. So you don't want to give up because there's stuff almost out there that might be very powerful. These are immunotherapies that you haven't explored. They're not out there, you know.
Right.
Thanks, guys. Appreciate it.
You've done Provenge, haven't you, Ron?
I have not, no.
Well, you know, again, I wouldn't wait. I wouldn't hang around to do Provenge. You can do Provenge and Prostvac. I mean, I don't know why your doc hasn't referred you for Provenge. I mean, again,
what's your PSA, Ron? What's your PSA? How high is it?
My PSA now is 360.
360?
Yes.
Yeah, and probably Provenge is, Rick, probably that's not it. You got to be a PSA pretty low for Provenge to really be effective.
But you have to look at Ron's PSA history. I mean, Ron,
right.
where was your high was really high, wasn't it?
My high was 800. My high was 800.
Oh, I thought
my low was.
I thought you were in the thousands.
No, my high was 800. My low
maybe
was
you're right, Steve.
140.
You know, everything I am doing Provenge. In fact, I'm doing my last leukapheresis tomorrow morning. I got to leave to drive to Oakland at 6 in the morning tomorrow, and it's raining like crazy here in the Bay Area. So, not looking forward to it. But you know, everything I've read about, I've read a lot now. You know, if you have minimal bone pain and if you have a PSA less than 20, and the lower it is, the better. My last one was 8, my last PSA. So that's the best candidate. Once you start talking about a PSA over 100, you're probably not going to do it.
Yeah.
And it's a pain in the ass. It's a total pain in the ass.
Does Kaiser support this kind of immunotherapy? I mean, with the cost of those things, do they participate in that?
Yeah, it's $90,000 for Provenge for the 3 courses, and I'm not paying a dime. It's a pain in the ass. So I got to go to the American Red Cross where they have these nurses with paper records, and it's like walking back in history or something for me. So there's pieces of it, and you sit there for 4 hours with two IVs going, you know, and they take out twice your blood volume as they reinfuse it back in. It's like dialysis sort of. So it's I must say, you know, if it weren't happening to me, it would be interesting. But you know, if it's happening to you, it's a total pain in the ass. I'm telling you.
All right, guys.
Okay, so let's just check in with a couple of the new people. Dan, is that Dan Louie that's with us?
No, that's Dan LaPlante.
I'm sorry, I didn't catch you. Could you speak up?
It's Dan LaPlante.
Dan LaPlante, okay. And have you been with us before?
I called in once quite a while back. I think it was the other call for back when I was on watchful waiting.
Okay.
I had a prostatectomy done in December. Everything's gone pretty well. I am having some difficulties with the incontinence. It's still pretty early, but just thought I'd call in and see if I could learn anything or if anybody had any advice on
Okay,
that.
so let me just come back to you. I just want to check in and see what we need to do here. And then I see Charles Smith, is that right? Do we have Charles Smith on the line or in the group? Okay. Well, we'll come back and check in again with Charles Smith. It's not a name I recognize. And then we have someone else that's called in that hasn't identified. Did someone call in the last 10 or 15 minutes and we haven't recognized you yet?
Yeah, this is Jay Curran, and I just called in.
Oh,
listening.
hi. Okay. All right. So so we know who that is. Okay, we'll put you in as number 8, gents. Now, I think what we will do is let's talk to Paul Hobson, because sometimes I know that Paul can't stay with us the whole time. We want to get an update from you, Paul, and then we'll come back quickly with Dan LaPlante and see if we can help him on this call. Although Dan, you may be better off on Peter Kafka's call next week, but we'll check in. We'll certainly check in with you. Paul, tell us how you're doing. And you're walking? Are you out the wheelchair? Are you in and out the wheelchair? How are you?
One flew over the cuckoo's nest.
Uh-oh.
Mid-December, I had spinal cord compression. I'm about 7 weeks post the operation now. My leg strength is good, but my ankle muscles and my knee muscles are not cooperating terribly well, so I'm having problems walking any real distances, and progress is fairly slow. So that's where I'm at the moment. Hopefully going to get, and the diagnosis is that I won't be able to go back home and live independently, that I'll need to go into a facility where I get nursing care. I'm hoping that when I get to that stage, I'll be able to escape from the nursing facility in a wheelchair or a mobility scooter and be able to do activities during the day that I like to do, but I'm not at that stage yet. I suppose the main thing that I'm looking forward to at the moment is that I'm doing this Lutetium trial at Peter MacCallum Cancer Centre in Melbourne, Australia, and on this Thursday I have my second treatment, so that's going to be quite significant. It's been difficult after the first one to work out exactly what's happening with it, so I'll get a much clearer idea once I've had the second treatment. So that's pretty much not much change in the walking thing, but Thursday have got the next batch of Lutetium, so looking forward to that.
So let me ask you a couple of questions, Paul. How are your spirits, first of all?
I think you described me as stoical. I'm pretty good most of the time. Got a little bit low when I was told that I'm not going back home again, but you know, pretty good on the whole.
And so I assume that you're still in the same rehab hospital that you moved to after you came out of the hospital. Is that right?
That's correct. Yes, I'm planning my escape from the geriatric ward as we speak.
Would that be with a walking frame, a scooter, or a wheelchair?
Oh, look, I don't know, but sort of the idea of empowered patients does not exist here.
You know, I have to say, you're a big guy. I wouldn't want to stand up to you if you had made your mind to get out of there.
The problem is I can't stand up terribly much, so
Okay.
I've got to find somewhere suitable to go, which I'm in the process of doing.
Right, right. And if you don't mind my asking, Paul, how are you managing with the situation around your wife? Because I know that, you know, you were somewhat of a caregiver for her.
The situation with my wife, for the benefit of the others in the group, she has Alzheimer's, has ended up putting her in permanent care. So she's sort of adjusting to that. So that's been difficult, but I think gradually settling in.
Okay.
It's been a fairly exciting 2 months.
Yeah, it sure has. And hopefully you've got some. I mean, do you have some support there, or are you doing this all on your own from the rehab hospital?
The thing with just the local support groups and Jim Marshall's support group are getting plenty of support. It's been very good type of thing. There's a good karma loop going.
Good. Good. People like Neville and some of the other people that are in the Melbourne area.
Yeah, no, they're all are getting quite a support, getting good support. But it's just been a bit frustrating with the actual cancer treatment. Christmas, New Year put the treatment back a few weeks.
Right.
And then they had problems with the radioactive isotope that they import from Germany, and that caused a delay of another week. So are finally getting the thing this week and are looking quite forward to that, because the first result seems to have been quite good.
How many sessions is this lutetium treatment?
I think they're doing 5.
Okay.
I suspect, though, that with some of the people who've had quite good results, they've delayed the further treatments. They've sort of almost put them on active surveillance type of thing.
Mm-hmm. So for those of you... I was just going to say, for those of you who are not familiar with what we're talking about, we've talked on the call several times, so some of you do know, I know, but this lutetium trial in Australia is a little bit similar to radium-223, except that the active agent is lutetium, and it's attracted to prostate-specific membrane androgen, which is largely, not exclusively, but largely on prostate cells, healthy and cancerous prostate cells. So unlike the radium, which goes to bone, this only goes to prostate-specific cells, and so it's much more targeted. That's sort of in a nutshell what we're talking about here, and we're not right now. It hasn't been. I don't think there are any trials in the U.S.
I think Memorial Sloan Kettering has just started one.
Okay. Okay. Yeah. You know what? Somebody told me that last week. I think you're right. Somebody mentioned that to me.
But part of this is a result of the better imaging, that
right.
They're able to target the prostate cells using a gallium PET, and then once they've used the gallium PET to target, they're sending in a nanoparticle with the lutetium isotope to do the treatment. So it's partly a result of the enhanced scanning that they can using counselling that you can see things better.
Right.
And once you can see things better, you're able to treat them.
Right. So anybody on the call like to speak to Paul or talk to Paul about anything we've talked about?
Paul, this is Peter calling. Yeah, we're with you. This has got to be a really difficult time for you and pretty scary. Is your compression fracture, has it immobilized you to the point of not ever being able to stand up or on your own, or are you okay with that?
No, what happened? What happened went in for an operation mid-December, so on the stage I'm able to stand up. I'm just limited as to how far I can walk at the moment. Yeah, I need someone to wipe my bum. I need someone to put my pants on, all this type of stuff at the moment. But look, Peter, thanks very much for the support. It's really great.
Well, we're all thinking about you. We're all with you, and we're all. I'm already selling tickets for scooter races at PCRI next September, Paul. So you better be there, you and you.
Well, the trouble is Jim Marshall's been on his scooter a long time. I'm going to have to practice sort of getting the speeds up. But
okay,
that's something at the moment that is probably an aim that I'd like to get over to LA.
Okay, well, as you say, and I've been known to say, keep your pecker up, and we'll look forward to talking to you hopefully next week, and good luck on Thursday with the next Lutetium trial, Paul.
Terrific. Thanks very much, guys.
Thanks. So I want to just welcome Charles Smith. Your microphone working now, Charles?
Could you hear me?
We can hear you.
All right. Yes, thank you. Not my first time calling in. I'm not sure I'm in the right meeting room, but my situation is back about a year ago, end of March, I had a radical prostatectomy at Fox Chase Cancer Center in Philadelphia, and over the last year, initially my PSA was undetectable, and then 6 months in it was 0.03, and then 3 more months after that it was 0.07, and so then I saw a radiologist, oncologist, and they recommended I start, whether you want to call it salvage or adjuvant radiation therapy. But I live up in northeastern Pennsylvania, so it was kind of hard to drive 2 hours back and forth, so I found a center up near Scranton, Pennsylvania area. Mm-hmm. But so I got another PSA like a month and a half after, and it's 0.1, and I'm not sure if this is the right meeting room, like I said, but seems like we have a lot of varied people here on the call with all their disease at all different stages, and thought I'd just sit and listen in, and I was hoping I had a cure, but looks like I had recurrence, and hoping to start radiology or radiation.
So let me say, I think you and Peter must have exchanged messages on Inspire, I believe.
Yes, I did. Correct.
Yeah. Yes, this is the right group, because this group deals with high-risk disease, recurrent disease, and advanced disease. So you've been hearing some people that have fairly advanced disease, but we also welcome people with high risk and with recurrent disease. If you'd like to put your email in the chat box and send me a note, you can do that, and we'll make sure we add you to the distribution list here. Okay. I didn't take good notes on your history, so either if your history's on Inspire, just give me your Inspire name, or else just drop your history down when you send an email to me. You should send the email to rd@ancan.org. I'll put that in the window for you.
Okay, thanks.
That's probably the best way for you to do it. No, my mouse is not working. I'll do it in a second. Just when again was your
March, literally the last day of March last year, 2016.
Okay, and then what was the did the post pathology, the surgical post?
Well, I had extracapsular extension on I think the left side. They said extensive, but I had no seminal vesicles or node involvement.
Okay.
And my Gleason score was 3+4. Then I had the genomic testing, which was a Decipher score 0.6, which is right on the border of intermediate and high risk.
Mm-hmm.
You know, and I had no positive margins either.
Mm-hmm.
So, you know, obviously the very first, the surgery went very, very well. I almost didn't even have incontinence. I have erectile dysfunction still, though. I take Cialis every day. That does seem to help.
Mm-hmm.
But the incontinence was what I was really worried about having surgery, and I didn't really have it for whatever reason. I'm 54 years old. I was 53 years old.
Okay.
I had the surgery.
Where did you have the surgery?
Fox Chase Cancer Center in Philadelphia.
Yeah, yeah. I mean, it's an NCCN hospital. It's good. Who was your surgeon?
Dr. Mark Smaldone.
Okay.
Charles, did you mention when we corresponded on Inspire? Did you mention that you have kidney issues as well?
No, that is not me. No.
Okay.
I think there is somebody there. I read that too as well. Somebody similar name.
So, and you say that your PSA showed up at 0.003 after 6 weeks?
6 months.
Up to 6 months. And then 0.007 after how long?
9 months.
And then it's now at 0.01, did you say?
Yeah, and it's where I just got it last week, so almost 10 and a half months, 11 months. The radiation oncologist up here just said, hey, let's just take it again, and I did. So it's obviously moving in that direction, and I wanted to, get it before, everything I'm reading says the sooner the better, your statistical outcome's better,
right,
the lower the number.
Right. Well, I was going to say that to you. I mean, we now have papers that say that earlier intervention is definitely more advantageous. And, I mean, there's papers that have come out in the last 12 months recommending earlier rather than later. But, one of the things that strikes me here so much, so significantly is that 5 years ago, we never did PSAs down to the 1,000.
Mm-hmm.
And here we are, and many men never got PSAs that were less than 0.1. And so, we've talked, and then probably starting around 2010, the PSAs to 2 decimal places became a lot more prevalent, and people would say, well, why do this ultra-sensitive PSA? And I would say, well, look, if you've had radiation, it probably doesn't matter. But if you've had surgery, it makes a lot of sense because you see the increase way, way earlier. So it allows you to jump the gun much, much quicker. And yours is a perfect example where there's clearly a pattern that is increasing. If we were still in the dark ages, you might not know for another 12 months that your PSA had gotten greater than 0.1. So,
mm-hmm.
The technology is really beneficial. I think you're probably making a smart decision to intervene, and it's not a bad idea to you know, continue watching a little bit, but probably if it was me, I'd be thinking the same thing. Have you done any consults with the radiation oncologist at Fox Chase?
Yes, I did, and the funny part is I have a friend up here in the Scranton area, which is about 100 miles north of Philly, and he had a different surgeon and a different radiation oncologist at Fox Chase, and they're working with a center called Northeast Radiation Oncology up in Scranton. My surgeon recommended a different radiation oncologist within Fox Chase, and he doesn't want to collaborate with somebody outside the network, which I was disappointed about. But you know, they were highly suggesting that I get, you know, I don't know. They're like, one guy says it's adjuvant, and the other guy says it's salvage. But I guess it doesn't really matter what you call it.
No, and you know, it's true. You're sort of falling right in the cracks there. I mean, the one thing that you want to be, I know that I would be requesting if I was in your situation is to start hormone therapy before the radiation, and you know, with a 3+4, you're probably not looking at more than 4 months of hormone therapy, but you certainly want to do that. Go ahead.
Yeah, so then I saw another radiation oncologist up in the Scranton area, and I'm scheduled to get, I guess, a CT or a mapping done next week. Mm-hmm. And then I've kind of already made the decision I'm going to go ahead with the radiation. I think it's like 39 sessions, but both centers did not recommend I get the hormone therapy yet. So
I think you need to go back to them. You can come back to me, and I can give you there are ample studies. In fact, Peter just referenced one. There's a new one, and Peter can maybe put the reference in the chat box for you. But there are so many studies that say that you should be doing hormone therapy around certainly adjuvant and also salvage. And there are two reasons, but probably the most important one is that we know that it weakens the cancer cells, and so they become more susceptible to the radiation, which is the reason why you need to start it about 5 or 6 weeks before.
Okay.
That's typical, but if you are having any issues, then I would recommend giving them some studies, which we can provide to you, or calling Smaldone and having Smaldone talk to the radiation oncologist, telling him that this is what which I'm certain they do at Fox Chase.
Oh, they certainly do. Both centers actually do. So the one up here is attached to a medical oncology wing of the center. This obviously Fox Chase has it as well, but I'm more fearful of the hormone therapy than I am.
Well, 4 months of hormone therapy is probably barely going to bother you. You won't even feel it for 6 weeks, and then maybe you'll start to get a few hot flashes and some other issues, minor, but then you're done. I mean, it's not like you're looking. At least now, you're not looking at a longer term, and you've got to give yourself the very best shot.
Okay.
Peter, do you want to add anything based on the study?
No, I just read it yesterday, and there seems to be pretty conclusive evidence that it does have a significant effect on the long life of people. And I know I met a lot of people at UCSF when I was going through my salvage radiation that were Gleason 7s that did not get hormone therapy. In fact, I have a good friend up in Napa that did not get it. And he even questioned Dr. Chang about it at that time. And I questioned him about it, but now I think it's changing. I think people are seeing that Gleason 7s, it has an effect too. Very much so with people with 8 or 9s, but it has a prolonged effect with survival with Gleason 7s, it seems, as well. I know it's not everybody's favorite therapy, that's for sure.
The only thing that I'm a mechanical engineer by trade, so I like reading into the statistics and stuff, and I read a lot, but I didn't see. I'd be interested in getting a copy of what study, because I didn't really see the major advantage, at least in my case. And also, you're not going to really know if the radiation worked or didn't work when you take the hormone therapy. Like, at least if you don't take it and you do the radiation therapy and the number goes down, you kind of know if it worked or not, right? Or is that a bad thinking?
Well, yeah, I mean, you're definitely right. There are a lot of issues, and it's something that I've had a lot of discussions about. The fact that it can mask the PSA, but the fact is that we just know that it's more effective, and
yeah, okay.
The PSA is going to wear off. The hormone therapy is going to wear off pretty quickly, and I just don't see why you wouldn't want to give it the.
Well, what's the length I mean, are you talking about for an 18-month period or a 12-month period or 2-year period or?
Oh, you're talking about how long would you take your hormone therapy?
Yes.
Well, I mean, the protocol, again, I'm not a doc, I'm not going to give you advice, but
right.
But the doc would, the protocol for a 3+4 is usually only about 4 months.
Oh, okay.
And the protocol for a 4+3 is 6 to 8 months, and the protocol for an 8 and higher is anywhere from 12 to 36 months. But it seems like 18 months is probably what's most favored right now.
The reference to the article from the New York Times that I read that someone sent me yesterday is in the chat box. It's called "Hormone Blockers Can Prolong Life If Prostate Cancer Returns."
I don't see it in my chat box.
I sent it to everyone.
It didn't come through to me. No, it didn't come through to me.
Did you enter, Peter? Hit the enter key.
Make sure it's still in there.
If it hasn't gone, Peter. You'll see it in your own chat box. It goes up into the chat box window if it's gone. If I see anything whilst we continue over the next 45 minutes, I'll put it in the window in the chat box window.
Okay, it's in now.
There it is.
In now.
Okay.
Okay. So and
I'll
just be sure to either put your email address in the window or to send me an email, and we'll start working with you.
All right, and I'll update my Inspire profile there too, and I'll get you that address. So.
Okay, super.
Thank you.
Pleasure. And Dan LaPlante, tell us a little bit about yourself. Do you have recurrent disease, or are you just dealing with issues around incontinence?
It's just with incontinence. I've had, I was on watchful waiting for about 1.5 years, and then I had prostatectomy in December.
Okay. So what I'd like to suggest is, rather than taking the time on this call, because whilst incontinence is very important, and we do talk about it from time to time as it rears its head for the gents who are on this call, that's really an issue that Peter deals with on his call next Monday at 8 o'clock, exactly the same time as this one, next Monday.
Okay.
And Peter will deal with we'll talk to you extensively and give you plenty of time. I just don't, we're running a little late, and this isn't really the right call for it. But you are very welcome to stay on. The reason we don't deal with it on this call is because for men like yourself, some men are very disturbed when they hear stories like Paul Hobson's and, you know, or Ron Shaheen early in the call. So we try to keep the calls separate, but everybody's welcome to every call.
Okay. Say, Rick, this
Yes.
is Jim Harrington. If you wish, I'm happy to talk about incontinence because I'm sort of an expert. And so if you want to pass on my email address, I'm happy to help him if I can.
Yeah, Dan, if you again put your email address in the chat window, Peter will make a note of it. I will make a note of it, and we'll pass you on. We'll put you in direct contact with Jim because Jim is truly an expert.
Yeah, an unfortunate expert, but I'm really an expert in incontinence. I've had everything.
Okay, thank you very much.
Sure, happy to help you if I can.
Or you can send me an email later, Dan, rd@ancan.org. It's in the chat window, or info@ancan.org. Both of them will get to me. Okay.
Okay.
All right. Let's go to Eric. Eric, you wanted to give us an update.
There we go. Can you hear me?
We can hear you.
Okay. Yeah. So I'm working with two different groups. I have my Berkeley Med-Onc and the UCSF. And UCSF is where I'm getting the experimental drugs. And my last PSAs from both of those had gone up substantially. They had they weren't the same. They were different values that I got from them, but they seemed to follow the same pattern. And so I got the UCSF one, and it had gone up, and then I got the Berkeley one, and it had also gone up. So that was disturbing. So last Monday, I had a bone scan and a CT of my chest, abdomen, and pelvis. And both of those came back positive. That is, that there was no change from the ones that were done 6 months ago. So the cancer is not growing, not going away, but it's not growing. So the PET inhibitor that I'm taking is preventing the cancer from growing any. So that was the good news.
Great.
It was good to get that news after worrying about the other because of the PSA going up.
Mm-hmm.
Dr. Agarwal at UCSF said that with this BET inhibitor, they have seen that. So it's not unusual. So that was all I wanted to update about.
So, in other words, they've seen the PSA start to rise a little bit, but the cancer not grow. Is that right?
Yes. Yes.
That's really good news. That's really good news. Not that your PSA is going up, but that there's no change in the. There's no change. I mean, we're all pleased to hear that. Anybody? Do you want to talk a little bit about just tell the guys about the BET inhibitor in case they're not on top of it?
Well, it's a phase 1B, 2A study that's going on, and it's I'm not sure how many are in the 1B, and they've already started the 2A, so I'm in the 1B, and they organized that into two groups: those that they gave Xtandi with, and those that they didn't, or enzalutamide. And they, I had already been taking it, so they had me. I had to wait to start the study until it was like a little over 2 months for the Xtandi to pass out of my system because they didn't want that to be influencing the study. I thought they could have just continued it but I guess they didn't want people that had it already. So I'm in the group that is taking it without. So I'm still taking Lupron, but I'm not taking anything else besides the PET inhibitor for the cancer.
What's the name of the trial drug?
GS5829. It's from Gilead. So they haven't given it a name yet, or at least they haven't published it to me.
Yeah. To us, uninformed, it's still GS5829. Cool. Okay.
And it's listed in the studies. If there's the government website that lists all the studies. It's listed in there, and you can read some about it there.
And my understanding of how the drug works, and this goes back to discussions a while back, is that it basically swarms the androgen receptors and sort of overpowers them, so they can't feed on the testosterone.
Testosterone.
That's a really huge oversimplification, but in discussions that we had privately and with Professor Bill on the calls, that's basically what we kind of agreed to, that it was that as to how it worked. So I'm going to move on, but Eric, that's a really good report.
Eric, can I ask how your shortness of breath has been doing?
Oh yes, go ahead.
Yeah, it still isn't any better, and I have another cardiologist appointment on Thursday. So they have, still don't have any specific idea beyond the fact that I'm taking the drugs that are probably causing it, but they don't. There's still no information as to why it's happening.
Okay, so we'll keep pressing on here. I want to jump down. Let me see.
Hi. What happened? Oh, juice.
Peter, can you mute, please? Wait, I don't think he's got the phone to his ear. We're getting Peter's grandchildren participation from Peter's grandchildren as well. Bear with us. Steve, tell us about your Provenge.
Well, it's not. I think I talked about it earlier. It's an interesting experience for sure. I don't know if it ultimately is going to do any good. I don't think it's going to do any harm. Like Rick says, it's like chicken soup, but expensive chicken soup.
Yeah.
So this is my last week, the last of 3 cycles, and I've tolerated it fine. I mean, when I get the reinfusion done, which is on the Friday, I haven't felt anything. I get a little flush as it's being infused, and that's it. And so then, PSA has gone down, which is probably unrelated to the Provenge. But so I'm still kind of doing my thing here. I don't know. After this, I'm just going to kind of wait and see what happens. I have 3 more courses of radium I could take. Blood counts have improved quite nicely, so I'm going to just hold those in my back pocket, I think, at this point.
And anything new to report on your PSA and your? Well, I know you do. Why don't you share your PSA?
So the alpha is essentially normal. It's 120, which is normal. High limits are normal, and the PSA, the last one I just got, what was last Wednesday, I think it was, is now 8, which is the lowest it's been. So it's kind of continues to fall. I'd like to see it below 1, but I don't know if I'll ever get there or not. We'll see.
Well, we should also add that at 8 from a high of 1,000 and something, correct?
Yeah, it's 1,000. Yeah, when I started this this journey, it was 1,000, so it's certainly a lot better than that.
Okay. Anybody want to talk to Dr. Steve?
Yeah, this is Jim, Rick. Steve, I went through Provenge. It was more than a year ago, and I didn't see anything happen. And whether it's going to extend my life, I think that everything we take sometimes, each one extends our life. Just put enough in a row, and then we'll be around a long time. The only problem I have with Provenge, other than the fact it takes time and it's a big needle, is in the third one. And I noticed that afterward you can get this slight flu-like symptoms, but it was very minor. It didn't happen in number 1 and number 2. Hopefully it won't happen to you at all, but whatever it is, it really is very minor. And yeah, $93,000, it's incredible. And they're still doing it. That's not approved in the UK. And sometimes there was a guy coming over from the UK and he was going to a second round. I didn't know you could do that. He was going to do it again. But then he paid for it himself because the UK, it's not reimbursed. Anyway, I wish you the best. Sounds like you're doing well, and I don't know how you really, what the metric is to measure Provenge, except that we're going to live an average of 4 months longer. But I did have a little problem with the last one, but very minor. It's really well tolerated, and the fact that it takes time and you got to go sit, when you put it back in, I had to go sit in the cancer therapy area, and it's not a lot of fun. But
I agree with you. It's not a lot of fun, and the leukapheresis is far worse than the reinfusion because it just takes so long.
It takes so long, yeah, and you can't bend your arm because they stick this big needle in and you bend it to slice them out, the doggone machine shuts off. And but that's right, and you just watch the thing pump it from one arm to the other and take out your plasma and put it back in 48 hours, yeah. But good luck to you, and I agree with Rick. You give it a shot, and see what happens. And I don't know how you measure it, and the people that I know that have had it really isn't any way, but just hope that we live longer because of it.
The study that they talk about 4 months, though, was a combined study of everybody, and really, once they broke it down into your PSA as a measure of tumor. The people with the PSA less than 20 actually survived for more than a year longer than without it.
Oh, so that's good to know, Steve. Well, you're into this. I didn't know that, but good to hear. I need anything that gives me some encouragement. So, thank you.
I don't know. Again, it is a pain in the ass, and I hope I don't get a reaction. I have a tennis match on Saturday, the day afterwards, so I hope I don't get.
Oh, I don't think so. I don't think I was surprised to get just the smallest amount, and let's hope it works. I'm sort of surprised the price hasn't gone down, but apparently not. They have these Provenge nurses, I call them, that run around in the East Coast and do this. So I guess the company's doing okay. I don't know.
Yeah, the company Dendrion, as you know, went belly up and was bought, and
Oh, did it? Okay. It was in New Jersey. I know that, and.
Yes, Princeton. Yeah, and now it's actually they have Southern California. They have a processing area there,
and I think mine was sent to Georgia, to Atlanta area. But once it came back, and they have the guy waiting right there for the UPS, and then they pick up their plasma and send it right on down. And it's got to be put back in 48 hours. Sometimes it just makes it. That's what I found.
No, I agree. Quite a feat for organization. American Red Cross in Oakland is the big center for this. They do about 40 a month, 40 to 50 a month here in Northern California, which is, I was advised to go there because they have like 3 of these machines. And
that's a good point.
They crank it out, and they're pretty good at it, I must say. And so I was a guy there with me this last time. I was, of course, hoping he didn't, with all the paper flying around, the nurses and stuff, I was hoping they didn't mix up our plasma and give us the wrong. So far, so good. So far, so good.
Very good.
Whilst we've got you there, Professor Jim, don't forget to talk to Dr. Stein about getting your tumor sequence, please.
Yeah, he explained a lot more about it today and the Listeria trial. And the trouble is the sequencing really won't work because it's a combination of Listeria and the pembrolizumab. Right. So I don't know. We'll see. He sure wants me to go into it, though, and I'll be sick from Listeria, but it doesn't last more than 24 hours. So
here's I've got 2 points I'd like to make, and I'd love other people to chime in.
Yeah, sure. Go ahead, Rick.
The first is that if you get your tumor sequenced, you're going to know whether you're likely to respond to pembrolizumab or you're not likely to respond to pembrolizumab. Now, the argument could be, well, without the listeria, you can't tell because the listeria does something to your immune system.
That's quite correct. It
Whether
does.
whether you've got the genes or you don't have the genes, that the listeria is the secret ingredient, and it's going to make you respond to the pembrolizumab. I mean,
that's correct.
Since the pembrolizumab is a PD-1 inhibitor, I just don't know. It's above my pay grade to know whether listeria could, even if you had non-actionable genes, whether listeria could change that. I really don't know. I sure would be wanting to know that before. Secondly...
Yeah, I do know what you did. I did talk to Dr. Stein about it. He feels very strongly about this trial, but why shouldn't he? Because he's involved with the company making these drugs, and his attitude is it's a prime time to get into it. You can do the chemo if this thing fails, and the trial is going to be 10 or 15 people here in the Cancer Institute in New Jersey, 8 centers around the country. I don't look forward to listeria, but I would look forward to chemo even less, I suppose. I've got a lot of feedback on what happens when you take listeria. Of course, the word conjures up horrible things such as death due to toxins in food and that, but this is a little modified version of listeria, and they give you 7 days of an antibiotic after you have the infusion of listeria, which goes over 2 hours, and the pembro is about a half an hour. So they give you these, and then and anti-nausea pills, and then antibiotics to kill the listeria that is put into your body, more or less. So we'll see. But I have brought up some of the things we talked about.
Okay.
I do very much appreciate your opinions, Rick.
Okay. I mean, I just don't see the downside from getting your tumor sequenced where you've gotten to a point where you're not responding.
Yeah, and I asked him that. And I think his attitude is, look, let's just get on with the trial. He's very pro. I believe he believes that my case, because I have no pain, and I don't make a lot of PSA, and I've got bone mets all over the place, puzzles him because they keep pounding me in the back, and I don't have any pain. But that's good news, of course, and so he thinks I'm a prime candidate for it. The men who are getting it, most of them, it's just, and after they have the pembro, then the PSA stays about the same. Maybe it goes down, maybe it goes up a little bit. We'll see what happens. I'll keep you posted.
I mean, the only other thing I would say is get a second opinion about the trial and options that are out there right now from somebody other than Stein, because Stein has a conflict. And
is he what?
The doctor has a conflict, that's all.
That's right, he does. And I thought I'd go to MSK. I mean, look where I'm in New Jersey. I can just go right on over there. There's no better place and get a second opinion. I quite agree. There's nothing wrong with a second opinion, certainly from MSK.
I mean, call up Dana Radcott, just a sec. Get an appointment with Dana Radcott.
How do you spell that last name? Dana?
R-A-T-H-K-O-P-F. R-A-T-H-K-O-P-F. She's Richard Foody's doc.
Oh, she's Richard Foody. Okay.
And
it's Dana?
Dana.
Okay.
D-A-N-A.
Okay.
She's got a lot of research out there. She's easy to do. You can get an appointment with her and just, have a chat with her about the options and, what's facing you and just don't just rely on Stein. I mean, I'm not trying to cast aspersions on him, but at the same time, he has a huge financial conflict in trying to get this trial. He's been trying to get this trial off the ground for 2 or 3 years, right?
Yeah, quite a while, that's right. And now it's off the ground. Yeah, they stopped it for a while because a patient given this inhibitor was somehow had a bad reaction to it, and then they started up again. But I actually was going to ask you for a name of MSK. That's good. Thank you.
Okay. Anybody else, Steve?
Jim, just one other comment.
Yeah. Sure.
The use of listeria, which is bacteria, which is actually sensitized. The company's called Advaxis, A-D.
That's right, Advaxis. Yeah, I see that. Right. Yes.
They're pretty far along in the treatment using listeria, modified listeria for the treatment of advanced cervical cancer. I think they're in a phase 2 or perhaps 3 trial there. And prostate cancer is also one of the targets, but you're just entering into that. But, the use of it for advanced cervical cancer is close to being approved. I think it's...
Oh, really?
Much
just listeria? No inhibitor, just listeria?
Well, they may be using a checkpoint inhibitor with it in the trial.
Okay.
I'm not sure for sure, and I don't know the PD-1 status of patients in the trial, but I haven't looked at that carefully. But I do know for advanced cervical cancer, listeria is looked upon as being a very reasonable solution pretty quickly, because that's a very devastating disease. You know, only 20% of people in the U.S. take the HPV vaccine, so we're still seeing a lot of cervical cancer.
Oh, well, thank you, Steve. I appreciate that. I didn't know that. I know that this pembrolizumab has been used in a lot of different cancers as an inhibitor for some time now, so we'll see what happens. But it's true that as far as prostate cancer goes, there's really no data that indicates that this is going to be successful.
Right. But for cervical cancer, there's a lot of patients who've had it. So you're concerned about, taking the listeria vaccine first.
And getting... well, you just get sick, you get chills, you get flu-like symptoms. Yeah, that's about it, and that happens in about 24 hours or so after you've had this treatment, or it can happen during the infusion.
But you're not one of 15 people that are doing it. Like I said, with advanced cervical cancer, they have hundreds and hundreds of people.
Oh, I see what you're saying. Okay, thank you.
Okay. I just wanted to make a quick mention. Paul Frieda asked us in the chat box about the ARV7 test, and because his doctor says that they don't do it. The fact is, they can do it. There is a requisition form from that Johns Hopkins supplies, because right now Johns Hopkins is still the only lab, although I heard that Genomic Health is going to be putting out their ARV7 test this summer. I haven't had an update on that, but that's what Phil Febo told me last time I spoke to him, who's their CMO, Chief Medical Officer. So any doctor can do it. They've just got to conform to the protocol, and the protocol is spelt out on the requisition form. I put the link to the requisition form in the chat box if anybody else wants to find it, or you can send me an email. And my suggestion, Paul, is that if you want that test, you want to find out if you're ARV7 positive or negative, then pass that information along to your medical oncologist.
Rick, this is Peter.
Yes.
Can I ask a question going back to Provenge on behalf of Mike to Dr. Steve and Jim?
Yes.
Yeah, Mike is going over for a consultation next week, and I'm going to go with him about the Provenge. I guess my question is, because he's got to fly to another island and so forth twice every week for this, is there any problem going by yourself? Do you need somebody else to help you drive, or
No.
I mean, can you go in and come out fine on either the draw or the reinfusion?
Well, let me, Jim, you might see what your experience.
Go ahead, Steve.
My experience has been, I probably could, but especially after the leukapheresis, which takes 3 or 4 hours, you're sitting there, you got these big needles, you got all your blood going out. It kind of freaks you out because you see this machine sucking up all your blood. I don't think I personally want to be driving or flying by myself after that. Now, the Provenge I've been very lucky with. That, it's about 30 miles from my house. I think I could drive home from that. But I would say someone should probably go with them the first time at least, just to be sure that he feels okay.
Yeah, I think that's probably a good idea. I did not have anybody accompany me. I just drove myself. They do make you sit, though, a while afterwards so you just don't fall over and something happened to you. But it's possible that, you could, when you're taking it out or when you put it back, you could get a little lightheaded or something. So in Mike's case, it might be a good idea to have someone go with him, but I didn't.
Yeah, I'm lucky because my wife, has been there the whole time, so she's driven. She has a little mini, just drive across the bridge, and it's really easy.
And another reason too is to have a little bit of company because it's kind of boring, you know.
It's boring. Yeah, the other thing is I downloaded an audio. You can't read because you can't move your hand.
You can't read. You can't bend your arm. No, I thought I could watch movies. Baloney.
So actually, I downloaded an audio book, The Girl from Venice, and interestingly, I should finish it tomorrow with the third one. I just
well, there's a plus there.
So at least I've read a book or listened.
Okay, thanks very much.
With my PSA running around 80, and you're saying that 100 is like already too much already. I'm almost like out of range already for Provenge. Because my last PSA was 80.
Yeah, I mean, Mike, we've talked about this before, and you know, my if it were me, I would be pushing to get that bone, that tumor sample done, and see what that tells me, because I think that's going to be a lot more significant and may possibly be a lot more helpful to you than the Provenge. I mean, the Provenge is good, but as Steve said, and he was right, he corrected me, and he's absolutely right. I mean, once the tumor burden gets fairly high, then it's not great. It doesn't have the same effect. I mean, and that's coming from the mouth of the guy that was the principal investigator on this. Yeah. I think for me, the priority for you is to get a tumor sample from one of your bone mets and get it sent to Foundation Medicine.
And I think you can do both. I don't think the Provenge, going through it is, especially if the insurance is paying for it, and you can, it's every 2 weeks, it's not every week, and it's only 3 cycles. So getting through that at any level, you just don't know what effect it's going to have. I think the data shows the lower your PSA, the better chance it may prolong your life, but that's not to say that at an 81 PSA it's not going to be helpful.
Oh. Yeah, and they're also saying that that my Zofigo has lowered my white blood cell count also, and I'm supposed to do 6. I have one more to go. But I'm already having trouble with my white blood cell count.
Yeah, they won't do the Provenge unless your white blood cell count is 3,000 and your absolute neutrophil count is at least 1,500. So you want to make sure that they're at least those levels, because they will not do the Provenge.
Oh, okay.
So check on your last complete blood count CBC, and if the white blood cell count is below 3,000, I believe it is, they're not going to do it.
Okay.
Yeah, well, we're just going over for a consultation next week, so we're not going to initiate it. We'll talk to the guy that does it and see what he says. But Mike's white blood cell count did come up from the time before, so he's not doing too bad.
Yeah.
I see that we have somebody on the call, somebody who's called in, and I don't think we've acknowledged them or identified them recently. Is there anybody that called in the last half an hour or so that we haven't spoken to? Okay.
It might be me, Rick, because I'm waiting for a bus. I had to get off the computer, and I've got to get a bus into town.
Oh no, because we have you identified as Peter Kafka. I see somebody. Okay. I see a caller number 9, and my sleuth sitting over there in Maryland, he hasn't figured out who caller number 9 is either. So
it might be me, Rick. This is Dennis. I signed in late.
Oh, well, we got you. How are you, Dennis?
Not too bad. I'm having a little side effects from the Lupron with my muscles and joint stiffness, weakness stuff. So. But I'm celebrating 1 year since my diagnosis, and I'm happy with that.
Good.
And be looking at the end of this month and getting my 3-month checkup and see what's happening.
Okay. And how are you still liking that Indian doctor there?
Yeah, I'm still satisfied with the doctor that I'm using here.
Good.
Dr. Fred Amen.
Right. Okay. We're doing pretty good here. I wanted to talk to Jeff. Jeff, are you still with us?
I am.
Okay. Jeff, why don't you tell the guys about the sort of pain you've gotten, and then I think there may be some people on this call who have gone through inguinal hernias, and so they might be able to have some input for you.
Okay. I can't put an exact finger on when it started, but what it's like, if you've ever been hit in the crotch with a baseball, or maybe wrestling with somebody, been kneed, you wind up with some pain in the inguinal area. And this is intermittent. It's mainly when I'm sitting down, either sitting in the car traveling or sitting watching TV. And it's not real bad. It's there. I know it's there. I can feel it, but I can't feel any sort of problem with the hernia, with a hernia. So I don't know quite what's going on. Obviously, I'm going to be talking with my oncology team next week. I don't know what it is. It's more on the left side than on the right, but it's on both sides, and it's mild. It's not a debilitating pain. I mean, I can still go out and blow snow with my snow blower.
Anybody else on the call had wrestled with an inguinal hernia after treatment? Okay. Eric has.
This is Jay.
Yeah. And Jay has. Go ahead, Jay.
I had one maybe 40 years ago, and it's come back, and the pain isn't terrible, but it's a burning pain, and I'm just living with it right now. I'm not doing anything with it.
I had mine surgically repaired. It was, I was diagnosed in April, and this was December of that year, 2014, and I'd already had the prostatectomy with the robotic surgery. So mine was bad enough that they told me I needed to get it taken. It wasn't an emergency, but I needed to get it taken care of immediately. I'm not sure where the line's drawn. I guess it wasn't strangulated yet. Yeah, so they operated on me December 31st of 2014. I got New Year's Eve in the hospital.
Perfect.
Yeah, and in the articles I've read, they said that it happens in 20 to 30% of prostate patients.
Huh.
So it's odd that we when I brought it up, there wasn't anyone in the group who'd had it, and I kind of dropped it then. No one had any advice, but reading the literature, it says that it is a relatively common thing. And I'm not sure whether it's because the lupron and the lack of testosterone weakens the abdominal sac or what. I'd had little problems with it, so it probably was pre-existing, and I did do something stupid that exacerbated it. I mean, I knew right away what was wrong, and we were about to leave on a trip, and I went to the urologist, and he said, I can't do anything, go to the emergency room. So I went to the emergency room, and they said, you don't need the emergency room, but go get it fixed next week. And so the next week I went to New York, and when I got back, I had the surgery. so it was okay. I didn't have any problems with it, but it, you know, it was very painful when, you know, that basically your intestines or something, you know, is coming through to the outside and getting caught in the bones in your crotch. So, you know, that hurts, but in general, I could just push it back in.
That's the actual critical piece with an inguinal hernia. If you can't push that little bump back in, which is a little knuckle of bowel, it's called an incarcerated inguinal hernia, and that's an emergency because you're going to end up with a bowel resection if that lasts for more than hours. But if you can just push it back in, then it's not an emergency. You just do it as a elective repair. You know, it's unusual that you're having pain on both sides. Do you have a lump on both sides also?
I haven't noticed a lump at this point. I will do some checking, however.
You know, when your doctor pushes his finger into your scrotum and says cough, that's to check for an inguinal hernia.
Yep.
You know, you see if there's an impulse there. I mean, you may not have an inguinal hernia. This could be just inguinal muscle strain or something else, because it's unusual to have it on both sides causing pain. Usually it's one side or the other.
Well, in my case, it is more on the left than on the right, and it's intermittent on both sides.
Yeah.
So, thank you
want to examine, make sure it's a hernia and not something else. I mean, that's
well, I'll be talking to my oncologist next week.
Simply go home the same day. It's generally speaking pretty minor.
Yeah. Okay, thank you.
Well, yeah, the problem with mine was that because I had the robotic surgery, they wouldn't go in the way they normally would, so we had to do it from the outside.
Mm.
So I had a 6-inch cut in my groin, and you know, there was a lot of pain from that, but it went away. You know, 6 weeks. I was okay. I mean, it wasn't instantaneous, but you know, and they say that the repair, of course, is not as good as if they'd done it from the inside.
Mm.
So the other thing is that, do you notice that it gets worse if you pick up something heavy?
Haven't particularly noticed that. Like I say, intermittent. It may be something with my hauling that snowblower around when I get out and blow snow for 2.5 hours.
Yeah, I could be doing it.
So Eric, I just want to circle back to your own situation. Did you agree with Agarwal that you were just going to continue with the GS 2589 or whatever the number is?
Yeah, for the time being.
Okay, indefinitely. Yeah.
Yeah, well, he's going to do, you know, the scans, and as long as there's no change,
right,
we'll continue to do it.
Okay, great. So we're getting. I think we've spoken to everybody. Is there anyone that I have missed or overlooked who wanted to say anything that I haven't acknowledged them? Or? Ignore forever hold your peace, as they say. I guess that's what Jeff Ledoux's going to be doing, holding his peace. So
I have a question, Rick.
Yes, go ahead, Jake.
This is Jake. I started Xtandi 2 weeks ago.
Yeah.
So I was wondering, did anybody that has been on Xtandi, did they ever experience neck pain and or numbness in the leg? Could that be Xtandi or could that be a spinal compression deal? Never noticed it until 3 or 4 days ago.
Well, I've been on enzalutamide now for about 4 or 5 months, I think it's been, and I do feel like I do get some soreness in my thighs and calf muscles, perhaps from it. It could be from Xgeva, which I also started. But if you're feeling any numbness more than pain, then then you definitely want to get an MRI, make sure it's not compression, nerve compression. But I must say, with the, I think it is the Xtandi, I do feel there's some sort of, hard to describe, but a painful sensation in my thigh and calf muscles.
Yeah, it is hard to describe. It's not really numb, but it's kind of like a. It is hard to describe. It's not painful. It's just the non-sensation that you know something's not quite right.
Yeah, exactly. And I only started on the Xgeva about, well, I just did my third cycle of it, and I do think it's more exaggerated. So I'm thinking maybe it's the Xgeva as well. So I don't know, but I understand what you're saying, and it was there with the Xtandi. I don't know.
What about neck pain?
I don't think it's listed with the Xtandi, but the Xtandi has lots of side effects, but I'm not sure it's listed as having muscle pain as one of them. I don't know. Rick, you know?
Muscle pain, yeah, is I think a symptom, but I don't think it stipulates there. I'm not sure. I haven't heard that, but I know that I think muscle pain is identified.
Yeah.
Well, I'll try. I've only been on it 2 weeks, so I'll try to just. I'll wait a while and see if it gets worse.
Well, it wouldn't hurt just to drop a note to your medical oncologist. I'd encourage you to raise it with your med onc.
Okay.
For what it's worth.
If there's any weakness at all, if you can't stand on your tiptoes for a while, or it feels like you can't push on the gas, any weakness at all, I certainly at that point would bring it up with your oncologist and get an MRI.
Great. Okay. Thank you.
Okay. Thank you. Thanks for all your help on this call, Jake.
I think Peter and I were at cross purposes for a while. He was typing in one name and I was typing in a name, and we kind of.
Okay. So guys, we've come to the end of the 2 hours. We do have a caregivers call tomorrow. So if any of your caregivers, or if you are a caregiver and you want to join the call, that's tomorrow at 4 o'clock. Tomorrow at 7 o'clock Eastern time. Sorry, 4 o'clock, 7 o'clock Eastern. So we will welcome you to join us at that point, or if you know anybody that is a caregiver. This is not only for prostate cancer. This is a caregiver, any caregivers for any sort of advanced cancer, but it is an advanced cancer call. So
I've been trying to talk my wife into joining.
It's a good call, and Renata is terrific. It's a very nice call, and if you can get Paula to join, it would be lovely. We would welcome her, and we promise her we will not repeat anything she says, please.
Okay, I'll tell her that.
Okay. There is a Chinese wall between the two calls. Okay.
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 Thanks for everything, guys.
Okay, my pleasure. All right, I'll say good night to everybody, and I'll see you next Tuesday.
Good night, Rick.
Good night.
Good night,
everyone.
Thanks, Rick.
Right, Rick.